the co-convener comes in. I think we'll start with my talk first, and so let's go. Can we close the door, please? So I think I can extend it a bit because we have lesser speakers, and if you all have any doubts, you can ask. So I want you to see this very carefully, this particular picture, and then compare it with this picture. Do you find a difference? Well, definitely the background is different. So this is called a negative polarity, wherein the background is dark and the image is bright. Whereas here, this is called a positive polarity, where the background is bright and the image is darker. So black on white, white on black. And also just see the font. So the font is closely placed. It is difficult to read. Here the font is adequately spaced. It's easier to read. The contrast is better in this. The colors are more brighter, and the intensity of the colors is also better. So this is easier on the eyes to read something like this, right? So that brings us to how we can use our devices. We're using them every day for all our waking hours, right? So how do we use our devices and not suffer them? And looking at how we take a look at the digital hygiene. What do we do to make our lives better despite us being gheraud by all the digital devices? So if this is something that you associate with, are you doing this? I think we all are. Like when the lights are off also, we are looking at our screens, and there is a glare from the screens. And of course, we are doing a lot of work in our offices also related to screens. So what is digital eye strain? It is a prolonged use of digital electronic devices. Now, why do we say digital devices? Why not a paper or a book? Because a paper or a book has got a continuous print which is even, whereas the digital devices are pixelated. They are based on joint pixels which are based in that shape. Every pixel has a sharper area in the center and a peripheral which is blur. So the blurred area causes a greater stress on the focusing mechanism. So look at this. This is a recent conference in ophthalmology. Can you see the pixels? Can you see it again? Look at the pixels. Okay. So whereas this is another one where this was projected. This is not a pixelated screen. It was a plain kapda wala screen where the projection was done. So this seems to be better on the eyes. Yeah. So this also causes convergence fatigue. So not just strain due to the pixels, but also due to convergence. Now, this is our own conference. Look at the pixels. You can see the squares. I'm not very sure if you can make out, but in this one you can make out. This was my talk on the first day. You can see the pixels on the screen. It's our own conference, and we are looking at it since 3 days. We are looking at these very screens, right? So it is not only the digital use of digital devices, but that causing visual and ocular symptoms, and together the entire symptom complex is called as digital eye strain. But because it's a symptom complex, should it not be called digital eye spectrum? Or better still, I would suppose it should be called as digital eye syndrome. Now, why am I saying this? I'm not over exaggerating. This is where these patients can go. They can go to the cornea specialist because of dry eye. They can go to the squint specialist because it induces your latent to manifest tropias. They can go to optometrist because again they manifest the smaller refractive errors, and neurologists because headache, eye strain, irritability, even sleep issues. So they can go to the neurologist or the neuro-ophthalmologist also. So it should actually be called a syndrome. Just look at the range of symptoms that can come. Yeah, so the symptoms I would like to divide into 3 groups. This is not some known classification, but it's easier to remember this way. Whether some optical or visual symptoms. These can be related to the focusing issues or the accommodative issues related to the phoreas. And of course, the second set is, of course, dry eye digital devices called dryness, irritation, burning, so all these ocular surface related, those coming to the cornea and surface disease specialist. And of course, related to the habit, how we are sitting, how often or how what extent or duration we are looking at the screen. So this is leading to asthenopia, plus of course the extraocular symptoms, including the postural and sleep issues. So there's a lot of it related to convergence. It may show up as problems with convergence, with accommodation and phorias. In children, it may lead to ESOs, whereas otherwise it may lead to exo. So again, the association with pre-existing low levels of astigmatism, hypermetropia, and presbyopia, which can lead to an increased strain kind of asthenopic symptoms. So we already saw these, that the screen brightness is important, the contrast is important. We saw in the first two slides the glare. What is the refresh rate? So in the earlier times when we had televisions which were not so good, the refresh rates were poor. So the critical fusion frequency, we need to see so many screens or shots per minute to be able to fuse them in our brain, to see them as a continuous image. We know we don't see a continuous image, but a series of images which our brain links together and makes it into a fused image, a fused video or this thing. So this is the normal critical fusion frequency. If the flicker is too much, then again eye strain is caused. In fact, this is known to be epileptogenic also. If the flicker is too much, it can lead to epilepsy in those people who are prone to it. So this is again, I was telling you about the polarity. Here, this is a positive polarity, negative polarity, and also there's pixelation. So also, we tend to look straight when we are looking at a screen, whereas when we are looking at a book, we tend to look down. So again, the exposed area of the palpable aperture is less. So the drying is less. And of course, there are innovations with respect to the screen factors also, like better resolution screens, matte finish screens, smoothing of the graphics. Look at this now. Now we are coming to the environmental factors. These were screen factors. Just look at which is clearer, which is better, right? There's no two ways about it. Look at this. This is in a dark environment. The ambient light is dark, but the screen is bright. There, the ambient is bright and the screen is very dark. So both cause eye strain, both cause digital eye strain. So here, just look at the glare. From behind, we'll be extended. We have only two talks here. So from behind, there's a glare coming in, and so we have to place our devices in a place where the light doesn't fall directly on the screen, and that is important. So the ideal is not even falling directly in front of your eyes, because then that will blind your eyes, not falling directly from behind because that will cause the glare. So it's oblique and preferably posterolateral is the ideal. So this is again an example of glare. And then we come to the ocular surface related symptoms. We all know about these dryness, burning, grittiness. All of us have patients where there's excessive screen use and they come with dry eye. And this is due to the tear film desiccation. Now, what is the mechanism in this? Well, you're continuously looking at something very carefully, you forget to blink. And the blink frequency should be around once in every 5 seconds, roughly. So 12 to 14 times a minute. But when we forget to blink, when we're looking at something very carefully, we forget to blink and there's a desiccation. The desiccation also depends on how much of the palpable aperture is exposed. And also, if you're looking up, there'll be more palpable. If you're looking straight, it will be medium. And if you're looking down, the least amount of palpable aperture will be prone to drying. So because of that, even the blink is affected. A blink is much easier, faster, and more frequent when you're looking down and more complete. Whereas when you're looking up, if you blink also, sometimes they're incomplete blinks. So this is very significant. So again, normal blink rate and incomplete blinks and increased exposure. These are all mechanisms in drying. Of course, the AC. Also, when we're looking down, when we're reading, whereas looking slightly up and an exposed palpable aperture, this is how the tear film replenishes itself, the blink reflex. And of course, these are the factors which pre-existing factors where the patient is anyway more prone to dryness, they will get aggravated in these conditions, right from endocrine factors to genetic factors, stress, contact lens use, they're anyway more prone. So what is the treatment then? Does it mean we should throw out our computers and digital devices? No, we are not going to go as far as that. We cannot any longer go as far as that. So what do? So we just need to have a multi-directional approach. It's no longer just related to the eyes, but it's very a habit kind of thing. So yes, workstation adjustment, user habits, ergo ophthalmological approach, ocular surface therapy for the dryness, optics and refractive for those symptoms. So your posture is important. If you're sitting too far or you're not sitting in a right angle versus too low or looking too down or too up, these, and look at the computer screen, the angles of the computer screen is not right. So we're coming to that. So this is something ideal. The American Optometry Association wants you to sit at 90 degrees at all joints. We are coming to that. We have a small video on that. And of course, we all know the 20-20-20 rule, but we don't know some other rules. We are just going to cover that. And the lighting should be more diffuse, more natural. So nowadays, there are some new bulbs available. These actually have been introduced. You can get them on Amazon just to grow plants. They simulate natural light, and so they can help grow plants inside your house in your closed door settings. But maybe we should do some studies and see whether they help out with our strain symptoms also. Yeah, and of course, blue light. How many of us know that the optometrist or the spectacle shops will all say, blue cut filter डालना है, blue blocking filter डालना है, मैम डाल दे, मेरे को ही नहीं छोड़ा उन्होंने, मैम डाल दे आपका blue. So then we need to understand, why do we need a blue blocking filter? So that is, of course, everything is related to the melatonin, because when the pineal gland is stimulated with blue light, it gets the indicator that it has to be awake. So blue light hampers melatonin secretion, and hence sleep is really affected. So 1 hour before sleeping, if you are using the digital device, try not to use it first of all. Try to, let's go back to our days of Nana, Nani, Dada, Dadi stories, like with our kids also, rather than showing them a screen. Maybe the last 1 hour can be used in speaking to them, talking to them, stories, etc., rather than seeing the screen, because it's not good for us. It's not good for our sleep cycle, and it's going to definitely affect our melatonin levels. So also, how far should it be? The 1 foot, 2 feet, and 10 feet rule for the respective digital devices. And of course, the angle, it should be downwards, not straight or up. And this is how it works. Blink every 5 seconds, 20 minutes, every 20 minutes, follow the 20-20-20 rule. And every 1 hour, you have to just get up and move for your posture. So lubricating drops, humidifiers are nowadays available, spectacles for uncorrected errors and for phorias. And of course, display settings we have to change, because in my office also, if I'm not comfortable with a very bright screen, then I switch off one of my tube light or one of my lights. Or if I want a brighter screen, I'll put them both on. I try to match the ambient lighting with the this thing, and I try to get the table in the right ergonomic position, as well as in position with respect to the lighting. So these are some USB humidifiers that are available. Anyway, if you're using the screen, you attach to the screen only. Okay, so of course, diet is important, exercise, lifestyle, sleep, good sleep. We cannot stress it even more, and stress management and workplace settings, as I said. I just want you to see this very locally made at our institute with all my staff and students made this video. Please see it.
Screen hygiene is the true genie, the soul of screen use. Be it online shopping, official work, or even entertainment, increased screen time gives rise to redness, itchiness, dryness, eye strain, focusing issues, headaches, as well as irritability, all under the ambit of digital eye strain. To protect your eyes, follow certain rules in your lifestyles. Distance, for example, mobiles at 1 foot, laptops at 2, televisions at 10. Angles, a backward tilt of the screen by 20 degrees, looking downward from your eye level by 20 degrees. All lower limb joints at 90 degrees each. Time rules expect you to blink once in every 5 seconds, to look at a distance of at least 20 feet for 20 seconds every 20 minutes, or simply close your eyes, and every 1 hour just get up and move. The brightness should be neither too bright nor too dim. The light should come from behind you. At night, switch on your night modes. Do not use your screens for at least 1 hour before sleeping, else your pineal gland will not let you sleep the next day. Remember, your eyes are going to thank you for following these rules.
Yeah, so this was at reel form, 75 seconds, and This is something that I used to take 20 minutes to explain, but in video form, it's just made it to 75. So yeah, this talk would be incomplete if we don't cover what it does to us kids, you know. So not just the eyes, but there are language delays. Children are talking less. There's more of autism, and this is all due to screen time. In our institute, we are a multi-specialty institute, 42 specialities. The three departments that are the most worried about screen time is ophthalmology, pediatrics, and psychiatry. They have already classified it as a addiction. It's already under addictions. So when they had the de-addiction OPD, I actually asked them, "Ki, will you do a de-addiction for screen time?" They said, yes, we will. It's already classified. So there we go. And then life skills. So impediments with life skills, definitely talking, social skills, all that is affected. Diabetes, because they're sitting in one place. Psychosocial skills I already mentioned. So we need a green time for our kids. We know that they need to look more at a distance. The myopia is increasing predominantly due to the near work, not especially due to screen time, but there's a lot of screen time associated sitting in one place and all the habit related issues. So again, we come back to the slide where we are involved. So what do we have to do now? We have to first correct ourselves, then of course our immediate community, our family, and we have to spread this message among pediatricians, how what they need to tell the kids when they are visiting them, because not all kids will come to us first. And I have had this presentation even for Indian Association of Pediatrics, and they have appreciated it. They need to be aware. Most of them didn't know most of these things. We still know a lot of these things. So community awareness programs, videos and awareness, like we did this video. And finally, we need to ask ourselves, are we relying too much on the screen? So this is something my students ask me when I tell them this talk. They said, ma'am, ye bhi to aap screen pe hi de rahe ho, ye talk. So what do we do? So does this mean that we have to go back to the era of blackboards, or do we have to some jump forward and become robotics or something, AI? Maybe not either of them. We stick to our digital devices, but do it with a balance. Thank you. Um, So I'll invite any questions if you all have, because this is something we are all dealing with directly also. I too have dry eye symptoms, and I remind myself of these rules. So if there are any questions, and because just check if we have our other speakers. Manisha Rathi, do we have? Okay. Monica Dahiya? No. And Dr. Raj Lakshmi, you're here? Okay. So we can have yours after this. If anyone has questions, you can upload your presentation, if whatever. So if we have any questions, we are opening this. Yeah. Yeah. Can she have the mic, please? Excuse me. Mic. Yeah, it's here. Yeah. Yeah. So that's what we said. The community is important.
Sorry. Hello. Most of the children complain that their parents are on screen. It's like so obvious when you talk to them
So
in
that's why we
OPD.
start with ourselves first.
Yeah, I think the parents need to be educated more, like how they behave. The
So
children.
schools, of course, we
Yeah.
can go to schools. A lot of schools take pride in showing them screens and taking classes. And many of our parents actually say that, oh, he's going to a smart school, my kid. So is it so smart after all? I'm not very sure.
Yeah, the habit of reading books is also reducing, subsequently because of all this.
But
Children.
especially now, we need to look at playing outdoors and looking at distances. So playing in the green, because again, books definitely it's something that they need to read, because the strain factor won't be there. But of course, near factor is still there. So anyone else wants to comment, madam? If you want to comment anything, okay.
Same.
Should we proceed to the next one then? Yeah,
Actually, in
ma'am,
our
please.
place also, we are trying to go for schools and address them regarding this digital eye strain. And recently, we had a talk to the residential school. So, as you say, they are engaging themselves and they are taking pride in telling that they are switching over to the PDF forms and Kindles and all these things. And as you say, most of them are not aware about the postural difficulties, the orthopedic problems that can arise later on because of the digital eye strain as well.
So, the most recent addition to the concerned group is the orthopedician. They
Orthopedician.
actually have these humps. The children have these humps.
Yes.
So they had pointed it out to us on our faculty group, the WhatsApp groups and all. And very much so, what the mind knows, the eye starts seeing, right? So when I was traveling in one of the airports, one kid was nicely very affluent family. He already had a 3-year-old kid already had that hump because he's continuously looking down. His orthopedic, the posture is changed. So it's very concerning. Yeah. So please go ahead, ma'am.
Yes, ma'am.
Yeah.
So at the outset, I would like to thank AOS for this opportunity. And I thank one and all being here also as the last session of the AOS midterm. So I'm here to talk something about the low vision aids. I'm going to highlight on the non-optical low vision aids. So maybe I'll get you through some of the important ones. I have no financial interest in this. So somebody who is blind or those with a low vision, they'll be obviously utilizing their alternate senses to the fullest to overcome whatever they don't have. So that is how, by making use of tactile sensations, the Braille system has evolved as well. So it started from 1815. The inspiration was driven from Charles Babbage de la Serre. He was a person who was very well versed with the shorthand, and he devised something known as night writing as a code language to talk among soldiers during the French Revolution. So Louis Braille got inspired by this, and he was a French educator. And what happened was, at the age 3, he was helping his father using this stitching awl for stitching leather and shoes and all, and he got injured in one eye. So he lost his vision in one eye, and subsequently, after 1 or 2 years, he became blind in the other eye as well because of sympathetic ophthalmitis. But being a very good educator, he had that persistence in his mind that he has to devise something, and the people who are blind, though with their abilities, should not go unused. So he devised this Braille code, and now it is there present in 133 languages. So we know that this Braille is a system wherein there are 2 by 3 rows of that is at 6 dots. So of which 1 or 2 will be elevated or engrossed, and that is how they palpate it and identify the letters. Now when we come to the people with the low vision or who are blind, one type is they have a defective field of vision. The central vision may be good, but their field is less. So here they make use of the reverse telescopes. So actually telescope is a device wherein a low vision person or a blind person can utilize it to see objects which are very distant. So they reduce the field actually. So when they use reverse telescopes, they actually are used as a field expansion devices. So this is one thing. And we have the other type of low vision, that is the central vision itself appears blurred. So this is what most of the time we encounter. And this one way to overcome this is using the eccentric fixation. For example, you see here that a person, for example, with a macular dystrophy or something, a letter or an image like A is falling exactly on the site of the macular dystrophy itself, during which time they will have a blurred image. So when they little bit tilt their head to get an eccentric fixation, the letter A comes to little bit the point away from their dystrophic area, and they'll be able to get a better vision. So this has been monitored with a scanning laser ophthalmoscope, which is documented here. Like when the letters are falling away from the area of dystrophy, they'll be able to read it. So this can be taught as a procedure to the people when they are in the learning phase itself, to develop little bit of an eccentric fixation so that they can carry on with their works. So where do we use these low vision aids? In the whole set of these conditions like retinitis pigmentosa, glaucoma, corneal scar, albinism, and so on. So with whatever we're going to see now, especially I'm going to concentrate on the non-optical devices. The people, they try to live a near normal life with the help of these non-optical devices. Actually, what are these non-optical devices? They are going to enhance the effect of the optical devices which the low vision person can use. So mainly the low vision aid comprises of, for vision, the optical devices will be, one is a magnifier, other is a telescope. Magnifiers are the ones which are going to help see the near vision, that is a near objects. Telescope is the one which helps the low vision person to see from a distant. So now our non-optical devices like a simple flexible arm task lamp. So this is going to enhance the effect of the optical aid. Here we are seeing a person who is using a magnifier, a handheld magnifier. By increasing the background illumination, it's going to enhance the effect of it. Another thing is here they are using a stand magnifier. So the only disadvantage with using a magnifier is the focal length. They have to use it very close. They have to bend such a way that they have to see the object, because the focal length will be less. So if you use a reading stand along with it, so this comes as a non-optical device which is going to enhance the effect of this magnifiers. A simple way of increasing the size of the devices that they use, like a large size keyboards in the computer, large telephones, large printed material, all this is going to help a long way as a simple non-optical way. So while we talk about this increasing the size, nowadays we are using these tablets, electronic readers, smartphones. So this activity of zooming and looking at it as already is in vogue now. So when we are not able to see what is there, we immediately take to this action of zooming. So people with this low vision, like 618 to 3 by 60, they very easily they make use of this zoom option. This has been described. This is an old article. If you say it, around 2014 to 2015, when it started coming up, several studies have been reported, and several apps are available for this low vision people, which helps to zoom. Not only that, it has been enhanced with certain reading softwares. Like this is a Chrome extension which comes as captive voice. They just display a PDF or something. It just reads aloud to a person who is having a low vision, who are not able to read it. The second thing is a immersive reader, which is a similar kind which comes with the Microsoft itself. Now, coming to electronic devices, it's something like a CCTV. You just put the reading material underneath it. It enlarges the font and gives it to the person who is able to read it now. So there are certain portable electronic or digital magnifying devices as well. So you just move it across, something like a stand magnifier. It just enlarges and shows. We can adjust the size of magnification we require on it as well. So when I'm telling this here, I can recollect an incident. Recently we had the medical counseling and we had the students coming. So we had one girl student who came with the under the visual disability. So that student is performing very well, having a very good score in the NEET also. But she's having some macular dystrophy, and she's using a spectacle mounted telescope for distance vision, and she's carrying this portable CCTV sort of a device with her to read, and she doesn't even use a transcriber or a scribe with her for writing exams, and she scored very well in the entrance. But we were only worried how she will be able to manage taking the medical course. That's the thing. So the other thing is increasing the color and contrast in the environment. So imagine a person with a low vision is given coffee in a black or a brown colored cup and saucer. They may have a chance that they may spill it, but they will not know which is a saucer, which is a cup. Suppose you're increasing the contrast by giving a white colored cup and you're pouring coffee on it. So that is the effect of increasing the contrast in the environment. So this is a basis for using this colored acetate sheets. When we used to have these printed materials, we just superimpose the colored acetate sheet on top of the printed material. So when I was preparing this topic, actually, I read some certain forums where students who are this kind of students who are low vision, but they are working hard to be in the IT field, or so they have given their comments like we also used to take Xerox of lot of foreign author books because they are all very costly. So, but everything is in very, that Xerox will be like a lot of white and black, that's all. It's very difficult to read it. So when they superimpose that sheet, which is very cheap as well, for every page, the same sheet can be used. They just superimpose it, and this contrast is going to give them a lot of. For example, you don't have to concentrate on the content. I've just put a page here. Now see this. Just by working on the contrast and brightness in the PowerPoint setting itself, I've changed it to this appears having a larger contrast, and that is going to be helpful for the people with a low vision. This is about the writing guides. These are called typoscopes. So they cut down the light from the periphery. So whichever line they want to read, on that alone they superimpose these writing guides or the reading guides, they can read it. And the same thing is used as a signature guide as well. So in that cutout spaces alone, they can just put the signature. These are tactile aids which are called the bump dots. So this we get even in Amazon. So each one can be taken out and can be stuck. And the important appliances at home, for example, a person with a low vision is working on a stove or a microwave oven. They don't know which is the start button. They don't know which is the stop button. They can just put it on it, and by palpatory, by tactile, they can easily identify it. So these are all enhancing their lifestyle as well. This was very interesting. They called the Notex. So this is just a cardboard with the cut steps on the sides. When they superimpose the currency notes, at which level the note is standing, based on that they identify the currency itself. But nowadays we have several apps. Like how many of us know that even in the present currency, we have these sort of tactile perceptions which are available. For example, in a 100 rupee note, we have a triangle and 4 lines here, which helps the person who is having a low vision to identify. Similarly, in a 500, there is a circle with 5 lines. As 3 blocks actually, 2 blocks with two lines each and one separate. So like that they'll be able to appreciate it. Now we have these apps. So they open the app, they put the note under it, and automatically the torch opens. It will tell it aloud to the person. It is a 50 rupee note, it is a 100 rupee note, like that. Coming to glare reducing devices. So these are, it starts from the simple ones like giving a cap or an umbrella to certain filtered glasses that the patients can use. People with aniridia, who have corneal dystrophies, lattice dystrophy, who have a lot of glare when they're going out, they can make use of these. So the principle in the Polaroid glass is that it cuts down the perpendicular light which is coming through it. For example, a horizontally Polaroid glass will cut down all the horizontal things, and only the vertical light will be allowed to pass through it. So this is the concept that they are using. And second one is the no IR, that is a no infrared filters. Now, so we all know that the visible spectrum is 400 to 700 micron, and when you see beneath that, what we have is the ultraviolet light. So in this ultraviolet, actually the UV A rays, which are in the early 300 to 400, this is actually been blocked by our cornea itself, and the remaining ones will get blocked by the initial ones 300 to 400 will be blocked by a crystalline lens, and the remaining UV B and C gets blocked by the cornea naturally. But when we have diseases related to the cornea or to the lens, then obviously they will not have the ability to watch the objects without any glare. So that is where we make use of these filters. These no IR filters are basically used for lasers, actually for laser safety. This is the image. Suppose you can see an image here without infrared filter, and when you put an infrared filter, this is how the clarity we have. So when we make use of this and give it to the patient with the low vision, they will be overcoming the environmental difficulties which they are facing actually. Coming to this photochromatic filter glasses, there are different colors. As we know in the IOLs also, what we are using is the yellow lenses. So they have a selective reduction of the short wavelength light, that is the blue light and the ultraviolet light, which will be helpful. So these are the different filter levels, and which conditions specifically they can be used has also been described. They have different colors like this. So whichever is suitable, that can be adopted. So how to use? Suppose a person tells already I'm having -5 or -6 myopia or some diffractive error. So there are these clip-ons, just like a magnetic effect. They just clip on to the actual prescription glasses itself. So they can just wear these filters on top of it. The next interesting thing that we should be knowing is something about this artificial vision devices. This was the ORCAM unit, based on which we have the present smart glasses, the smart vision glasses. So what is this actually? The low vision patient wears these glasses. They have a miniature camera on the side near the frame, and when they focus on an object or a person in front of them, immediately it will be giving a bone, by way of bone conduction which is present near the ears. It will be telling them like a person of so much age, this color is standing in front of you. And it may even read out. When you show the book to them, it will start reading out the content of it. So that will be very helpful for a person who is blind. So this is the present day smart glasses. With this picture, I've screenshot I've taken from the Amazon just yesterday. I wanted to check whether it's there, and around 20,000 it costs. And see, they tell that it for currency identification, color detection, text interpretation, multiple languages. So this is the AI smart glasses. The other very important thing for day-to-day life which a low vision person needs is these mobility assisting devices like long canes, GPS navigation devices, auditory signals for crosswalks, talking thermometers, talking glucometers, talking watches, and the guide dogs. So with the help of these GPS, patients with a low vision, they can participate even in the Paralympics. So they can, we have heard when patients taking part in the persons who are taking part in several sports activities with the help of this GPS. So we don't have to tell about the importance of these guide dogs and the auditory signals. This is something interesting which I found. That's a smart cane. This was discovered by our own people from the IIT New Delhi. So it's just a attachment to the regular long cane that they can have. So with this cane, when they reach an object, for outdoors they have a distance of around 3 meters. When they come across an object around 3 meters in the outdoors, and indoors up to 1.8 meters, it will immediately start vibrating and giving a detects the obstacles and vibrates as to how far they are. So you're reaching some bench or a table in between, like that it will start vibrating and given. So this is in a nutshell about the different non-optical low vision aids, and with the help of all these things, the low vision people are trying to lead an independent life and a near normal life as well. Thank you so much for your patient listening.
Thank you, Dr. Rajalakshmi. Please, we're open to questions. There's a mic there.
So, what filter will you suggest for a patient who has a centrocecal scotoma? I mean, 618 vision,
Yes,
best corrected, probably B12 deficiency or some toxic kind of myopia kind of patient.
okay.
Oh,
Specifically, like we have to try and see, sir, actually. Mostly what we want is to reduce the short wavelength. So generally we go for a yellow filter only. We start with that, and then maybe we
so
have to.
these clip-ons are available on Amazon.
Yes, sir, it is
We can
available. Yes,
clip
yes,
on. We
yes,
have
yes.
to
We can
just
definitely
select
like a
one.
trial and error, just like we do the contact lens trial, we can try it and choose it.
And that reading device which you mentioned,
The smart glasses.
no, the thing which moves over the paper and that
Portable CCTV sort of. Yes,
yeah,
sir. It's widely available
that's
and
one.
people are using it
From
for
Amazon we
their
can get.
education. Yes, yes. Yes.
Just one input when you were saying na, that they have to be trained to look beyond an extra foveal
Yes, sir.
fixation.
Yes, ma'am.
So we found that since we are running a disability center, one of our low vision aids is a prism. So it automatically shifts
Image.
the image,
Yes. Correct.
and even the fields, it can act as an annular prism can act as a field device
Expansion
also.
itself.
Yeah,
Yes, ma'am.
a field expander. And yeah, so that was really good, and it's encouraging to see these children, the genuinely those who need come into the medical field, except that we don't know how they'll
How far
look
they'll
through the
be able to
microscope,
sustain.
or yeah, and also where things involve colors like the hematoxylin,
Hematoxylin,
eosin,
eosin.
and this is something we need to tell them and their bosses or their HODs that this particular thing might get affected. And usually we are always asked that uh, when in their MBBS they're given fitness, will you give them fitness for PG? So the technical thing is that in India there are no rules to make a child unfit if he has a color vision deficiency. We cannot make a child unfit for a medical course yet, not even for post graduation in ophthalmology. So what happens usually, and I've seen this as a trend by experience, is that when the child has undergone MBBS, he knows he's not good in that topic. So he won't put himself into that subject which
Which
involves
involves
microscopes
colors.
and hematoxylin and eosin. And I think there's an article by Dr. Kirti Singh's group which discusses the color vision and studentship, like what kind of courses such students prefer or don't take. So maybe you all can have a look at those. So it was very nice, and you had a very overall 360-degree coverage. Would anyone else like to ask anything? Or
Regarding that admission to the MBBS course, I have a personal opinion that I think MBBS should be allowed, because you have that opens a field for going into research and non-clinical branches as
very
well.
true,
So
and
that then you should
yes,
not be
and
stopping
they
at the graduation
automatically
level.
don't choose a branch where they know they're not faring well with respect to their colleagues. So it filters them out on their own. They would not choose such a branch for PG. So in a way, it's fine. It just self filters itself. But
And
there is no.
studying so well, we asked we called her parents and we spoke to her. Like, suppose you choose some IAS or some administrative service, you will be shining very well. Why don't you think about it? Then the feedback from the student was like, they did not give me a treatment for my condition. I myself wanted to be a doctor. That was my aim from the beginning.
So
That sort of.
these are very committed students. Most of many at our institute also have joined medicine for this precise reason, that it is we who are affected. So
Yeah.
this is affecting us so much that has become our passion.
Correct.
And we cannot go into a field without having a passion for it. So I think they will do great things,
will
maybe,
rock, yeah.
hopefully, and things should improve. Yeah. Thank you so
so
much.
much, ma'am.
Maybe we all come for a picture if we don't have the other two speakers, Dr. Manisha Rathi and Dr. Monica Dahiya. Just confirming.
If we have some time, then a couple of questions maybe
Yeah, sure. We
related
have
to
time. We have time.
myopia only. The usage of atropine, low dose atropine. So what's your protocol to start? Do you wait to document? Do you document the progression for a year or axial length elongation, and then you prescribe, or all children 6-7 years of
No,
age
so
who are
this is
myopic?
something that was being discussed in the morning also, and even though I'm not a pediatric ophthalmologist, and if there are someone in the house, but yes, I would say that documented is easier to convince the parents, and some people, especially the general practitioners or the general ophthalmologist, without even consulting a pediatric ophthalmologist or asking them what their protocols are. Some of the pediatric ophthalmologists, some friends of mine were saying that there has been a big issue where the explanation and the counseling is not done adequately, and then the child buys them and doesn't use them. So even the drops and even the glasses, the specialized glasses. So is there anyone else in the house who would like to mention what they protocol they follow? Because I'm not a pediatric ophthalmologist as such, but yes, in our institute, there's lesser use of the glasses because it's a government institute, and our the type of patients we get would not be able to afford that kind of thing. But more use of atropine, yes, low dose atropine. We do that. Any other questions, or should we wrap up and we can have a common photograph for all of us who are sitting here? Because usually community ophthalmology, we don't have enough people on the chairs. But yeah, it's very encouraging to know that it is the case. And usually it is the people from institutes who would be the speakers, which has been there in this case. But then uh, it helps to know what's happening in all over the country. Yeah, thank you so much. Come, please.